Welcome to the LDN Radio Show, brought to you by the LDN Research Trust. I'm your host, Linda Elseygood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose Naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. Today we're joined by Dr. Paul Anderson, who's a naturopathic physician and medical director and founder of the Anderson Medical Specialty Associates, or AMSA. He is a recognised authority in the field of integrative cancer research and the treatment of chronic diseases, genomic conditions, and autoimmune and infectious disorders. Thank you for joining us today, Dr. Anderson.
Thank you very much for having me.
First of all, could you tell us about who Dr. Paul Anderson is? That would be very interesting to our listeners. They always like to know what makes the doctor tick and what's made them the person they are today. How did you get into medicine?
That's always a good place to start, I suppose. About 40 years ago, I started in the technical side of medicine, working in medical laboratories, and so I had a long workup into medicine, and got a chance through working in labs to see not only how that end of medicine worked, but really interacted with lots of different practitioners, and worked to the point where I had actually owned my own laboratory and was doing fine there, and realized that I was just getting kind of bored with that part of medicine. So I considered many different roads to go into being a practitioner outside of the laboratory world. And about 25 years ago, I sold my laboratory and went and finished medical school. And I did that in the state of Oregon in the United States. Mm-hmm. And when I was done and got out, I was a general practitioner, seeing family medicine cases. And what I noticed was that my patient population started to move from the typical general practice to more people who were not being helped by the standard medical system. And so I began to do more and more integrative and naturopathic medical care, and that brought more and more patients with more difficult problems, especially in the areas that you mentioned of cancer and chronic illnesses. And that's really been the last 20 years of my practice, has been focusing on cancer and chronic illnesses.
Mm-hmm. So how did you discover that people were using LDN?
So I think, one of the ways that makes it a little bit easier to discover LDN is if you start seeing people who are chronically ill or who have cancer, you start to see people using all sorts of therapies that you might not as a general practitioner. And early on, I would say my first exposures to low-dose Naltrexone were probably between 12 and 15 years ago. And it was pretty rare back then. It was just something that a couple of practitioners I knew were doing, and I didn't give it a lot of thought. And I knew about Naltrexone and Naloxone from the point of view of emergency medicine and their high-dose use, but I'd never heard of this idea of being low-dose. So I started looking into it because that's about the time I started to get more advanced cancer patient cases and advanced autoimmune cases and things of that nature. And it was really, as most people who've looked into it know, if you go back 10 years, there was very, very little information anywhere. So it became the kind of thing where practitioners like myself who were interested in using it would compare notes, essentially, and say, this is what I did, and this is how it worked out, and what do you do with it? And then people started to write more, and then the website was developed and all of that. So it's really been a what I would say in the beginning, a slow onset through the last 10 or so years, but in the last, I would say the last 7 years or so, where I got involved in more formal cancer research and was doing a lot of research into different therapies that we could bring in for advanced cancer cases. I very much reignited my work into looking into Naltrexone as a therapy, and accelerated the amount I used it both in my cancer patients as well as my chronically ill patients.
So what cancers have you tried to treat with LDN so far? The most common cancers that we see are, well, likely the most common cancers that are seen anywhere, although we tend to see people who are in more advanced stages. And there's some of the more common ones like breast, prostate, colorectal cancer, advanced metastatic disease from, other types of other primary cancers, such as metastatic disease to the bones and liver and the brain, et cetera. And also, we see a fair amount of primary brain cancers as well. And I would say, again, over time, when you acquire a new therapy, you always, go a little slow in the beginning, and then you start to use it more. Over time, we have, with a few caveats, incorporated low-dose naltrexone into most of our advanced cancer cases now across all of those types of cancer. So what started with trying it here and trying it there, and then, as I said, sharing case notes with other physicians, now it's more part of our first-line therapy. And really, although the cancers I mentioned are the most common ones that we see a lot of other unique cancers, and we'll try it in those as well. Mm-hmm. We're often asked if the LDN cancer treating doctors use LDN for leukemia. Have you had any experience of that?
We do see patients with hematologic cancers such as leukemias and lymphomas, and I would say we've used it in some of those cases, but the numbers of cases of hematologic cancers that we see kind of go in cycles. And so the last big cycle we have was sort of at the ending of us using a lot of LDN. So we have no problem using it in those types of cancers because it makes a lot of sense. We're using it in the few hematologic cancers we have right now. But we're kind of waiting to acquire more patients to see if we're noticing particular trends with treatment, because as is logical, and as most people know, every cancer behaves differently, but also every cancer in an individual patient behaves differently. So you have to judge the therapy on a lot of points.
Mm-hmm. And we know that LDN isn't a standalone treatment. What other treatments do you use alongside of LDN for cancer?
Yes, we certainly use a lot of other therapies and treatments in collaboration, because cancer is such a multifactorial disease. We said remedies. Actually, if I was in Canada, that would be the appropriate term.
Okay.
That's what they call it up there, which always throws the Americans off. But treatments and therapies. So we in our clinics, we're very eclectic in using different types of therapies, and we try not to judge anything as far as, well, that comes from the natural world, so it's better or worse, or that's a chemical, so that's better or worse, or whatever. What we really try to do is use not only the number of years I've been involved in medicine and the case reports and the people that I've seen, but also as science emerges, we try and see where can we have synergy, so that this, especially with cancer, this sort of very monstrous disease that can morph and change and do all these different things, you really have to treat it in a very well-rounded manner, or it just gets away from you. So, in addition to low-dose naltrexone, which, as I said, over time has become one of our cornerstones, we use a number of herbal type remedies. Things such as high-dose curcumin is a pretty common treatment, and there's a lot of research on curcumin with cancer. And if you look at the way curcumin works, for instance, or there's another plant extract called boswellia, the way that those two things work, they go and they try and change the cytokine landscape, which is usually pro or anti-inflammatory triggers that we want balanced. In autoimmunity and in cancer, those things they go awry in different directions. So one of the synergies that we see is LDN works on those triggering molecules in one way, and then things like, say, boswellia or curcumin or there's a host of other things work on kind of the other side of the equation. And what we often find is when we put those things together, they actually work in synergy. The other thing that we do is we do a lot of intravenous therapy with nutrients and other nutrient-type interventions through IV. And so we'll do basic IV nutrients to help people recover from chemotherapy. We'll do things like high-dose vitamin C, other experimental types of medications that we use in cancer through IV therapy. And then we do a lot of diet and lifestyle interventions, because whether you have something like autoimmunity that's advanced or cancer, it changes your whole life. And so you have to often be more attentive to what you're eating, the kind of food you're eating. In cases of advanced cancer where you can't eat very much, you have to be extremely careful about what you are taking in. So all of those things are very much cornerstone to our therapies. And the other thing that people often are curious about is, well, do you work with people who are getting, say, standard therapies like chemotherapy or surgery or radiation? And the answer is yes. Most of our patients, we're actually trying to collaborate with their oncology team, or in the case of autoimmunity, maybe their rheumatology team, so that we can keep the person as healthy as possible through the standard therapies. And then a lot of times, if the standard therapies stop working, we take over the complete care of the patient. So we do quite a bit in trying to be as holistic as we can in the therapies we do for people.
Mm-hmm. And have any of your patients reported any negative effects while taking LDN?
Not really. It's one of the nicest things about using LDN is it has almost no, negative or adverse sorts of events. One of the caveats to that is, of course, if people are taking opiate pain medications, there's some people who have complete intolerance, and the two are exclusive of one another. Mm-hmm. And then there's some people where through very low dose strategies and ramping the LDN up extremely slowly, we're able to actually find a dose of LDN that they can tolerate that doesn't give them breakthrough pain from opiate blockade. So that's the one time where we have to walk very carefully into using it. Otherwise, people will sometimes experience transient things, such as they'll maybe have very aggressive dreams that they have when they start LDN, or some people sleep better, some people have sleep disturbance, and those are generally transient. And what I have found just clinically over time is in people who are sensitive, the two things that we often do, one is we may ramp the dose up of the LDN much more slowly in those folks, and sometimes that just helps because it gets into their biology a little more gently. And the other is, and this is sometimes seems a controversy amongst the pharmacists, et cetera. There's the pharmacists that recommend only dose at night and then there's only dose in the morning. What I generally tell people is if they're having trouble with their sleep, we usually move the dose to the morning and it's not a problem. And we may back down on the dose and ramp it up more slowly. But for most people, we find dosing it in the evening, they do just fine. So really, those are very transient. They're not really side effects as much as they're getting accustomed to the LDN.
Mm-hmm. And what about dose? What dose do you start the same dose, whether it's for an autoimmune condition or cancer, or do you alter the dose, starting dose between the two?
It's really, I would say that's something, the more I've used it over the years, the more subtle I've become with dosing. So I used to do a pretty standard dosing escalation, at least in the U.S. It became pretty standard of 1.5 milligrams and then 3 milligrams and then 4.5. And most people tolerate that actually quite well. I have some colleagues who work in cancer who don't escalate at all, and they just go right, they go right to 4.5. I've never done that, but I do know some people who do it. But what I've noticed over time is the more people that we have, that just like you see with anything statistically, the more you find people who are a little more sensitive. And so what I tend to do now with folks is if I look at their case and they're extremely sensitive to therapies and they react to a lot of things and all that, I will often kind of break up that three-step dosing or three-step ramping up process into maybe 5 or 6 steps. So some people I start as low as a 0.5 milligram and work up. And that takes, especially in the autoimmune patient who's very sensitive, that'll take most of these unusual, effects in the beginning out, and so it's much more comfortable. The other time, if we have a patient who say is on opiates, but it's not a high level, and they know that they could have breakthrough pain, and they know that ahead. Those cases, I always start very low at a 0.5 milligram, and then you ramp up by a 0.5 milligram. What I tell them is you might get to, say, 1.5 or 2 milligrams and fine, there's no breakthrough pain. You get to 2.5 milligrams and you have breakthrough pain, then we know that the max we can give you while you're on the opiates is, 1.5 milligrams, for example. Mm-hmm. So in cases like that we go a lot slower and a lot lower dosing. But really most people, if they seem they're not terribly reactive, not terribly sensitive, my average is the 1.5, 3.0, and then 4.5.
Mm-hmm. Now, the other conditions that you treat, let's start with chronic diseases. Which of those have you treated with LDN?
I would say that in the non-cancer chronic illness category, the first big group, of course, were people with autoimmune conditions because it makes a lot of sense from a inflammatory biology point of view. So people with multiple sclerosis, Crohn's, inflammatory bowel diseases, lupus, scleroderma, that sort of thing. And then what we started to see was there was a lot of crossover with our autoimmune advanced patients, and then more recently our patients who had chronic infectious diseases, such as people with what we call Lyme complex illness, where it's not just a single Lyme infection like a borreliosis that's acute, but it's complex where they have Lyme that they've acquired, but usually those folks also have other, 1 or 2 viral problems and maybe a fungal thing, and so multiple infections. And we actually have some cases now where, and I think what led us into that originally, a few years ago was we'd look at these cases and they weren't getting terribly better by the standard therapies. And we would see, they also have some autoimmune-like problems. So they're autoimmune antibodies are a little elevated, but they're not diagnostically elevated of anything. So the body's having an autoimmune reaction. So we start them on LDN. And what we started to notice was a lot of the anti-infective therapies seemed to work better once we added the LDN in. And I really think what probably goes on is that the LDN, through this receptor and cytokine manipulation, calms the immune system down enough so that then the anti-infective therapies work, but also the anti-inflammatory and the healing therapies are able to work as well. So I think that, in addition to autoimmunity, the complex chronic illness that always involves some infectious disease, that's been a really wonderful addition to the use of LDN.
Mm-hmm. And what do you recommend in the way of diet for people that have, say, an autoimmune condition?
Yeah, that's it's diet is always to a degree individualized in people, but there's always the starting place that we try to have with people. The first thing is to find out, what they're actually eating right now. And one of the interesting things in being a physician is people often will tell you what they think you want to hear as far as what they're eating, as opposed to what they're really eating.
I don't eat McDonald's, honestly.
Yes, I do. Yes, and so you have to get through that first. And the other thing is, of course, they have to tap into the idea that their diet does make a difference. But once you get past those things, what we start with are what I generally call the basics. So beyond the more specific changes, such as one person might need to go, say, on a ketogenic diet, or one person we might want to do a low carbohydrate, a high protein approach, and that. Beyond those changes, the cornerstones that we talk to people about are, number one, what are the actual foods you're eating? Meaning, are they from as clean a source as possible? Such as, are you able to get organic produce? And especially, the Environmental Working Group has the infamous dirty dozen foods, so the most, the highest pesticide foods. We try to at least get people to get those things, which are very common fruits and vegetables, that people eat those things in the organic form. And if you're eating fish, we look for the cleanest sources, but there's no clean, anything totally clean, but the cleanest sources possible. If you're eating land animals, again, the cleanest sources possible. So cleanliness of the food is sort of the first thing. And then the next thing is actually looking for what would give me the most natural source of nutrients. And so if you start in the plant world, richly colored vegetables are, almost no dietary intervention argues with vegetables. Richly colored vegetables are a huge cornerstone, because they not only give you a high density of vitamins and minerals, they also give you other chemicals like polyphenols and flavonoids that are anti-inflammatory, and they just do all these, amazing things. And most modern people eat very little of those things. So our first goal is educate them about the cleanliness of foods with respect to, say, pesticides and herbicides and all that. Next thing is eating a lot of color from the plant kingdom. And then beyond that then is cleanliness in the protein sources. And of course, there's some people who are sensitive or allergic to certain things. Some people don't do well on dairy. Some people do. Some people don't do well with certain animals. Some people do. We customize it from there. And then after that, we really then look at, are they really inflamed? If they make the basic dietary changes and they're getting clean food and it's all that, and they still are having inflammatory problems, then we may look at, in very inflamed, say an autoimmune patient, and also a lot of our cancer patients, because there's a lot of inflammatory triggers in both diseases, we may take a step back and look at the macronutrient load, meaning what's the percentage of carbohydrates versus protein versus fat you're eating. If the sources are clean, then often the inflamed person does better by cutting back on the carbohydrate load and adding a bit more protein and fat. And actually, that's actually more of an anti-inflammatory diet for them. So it sort of goes in those layers. The first is education and cleanliness of the food, and then there's high-density nutrition, and then it's kind of customized from there on out.
Mm-hmm. And what about supplements?
Yes, we do use a lot of supplementation with people. One of the things that we try to educate folks is when let's say you have cancer or advanced chronic illness, when you start treatment to try and undo those things or minimize them, it's sort of like the top of the funnel. You're doing a lot of different things. So it might include, one of everything. You've a dietary component. You maybe have a movement and exercise component. You may have medications and LDN and supplements and all this stuff. Mm-hmm. And then our goal over time is that we want less and less and less of those things because they're getting healthier. But all that to say that on the front end, often the supplements are there not so much because we can't get some of that if they clean their diet up, like we talked about, but because they're so deficient to start with. We talked to them about filling the tank, and the tank's been empty for so long, and they've been so sick that the supplements are just like their name says. They're there to supplement even a good diet and try and get the good things back in. And there, generally, we stick to it's sort of like the diet approach. We stick to the basics of the things that are most commonly deficient, such as the water-soluble vitamins and minerals. And then we will look at the condition, and we may add, say, supplemental. We talked about the curcumin or other herbal things that aren't a vitamin or a mineral but are necessary in the disease state. And basically, with a chronically ill person, we'll either say, the tank is empty, we need to fill it, or we'll use a banking example and we'll say, you've overdrawn your nutritional bank account. And most people understand what overdrawing their account is. And we have to get you up to zero before we can get anything good going on. So that's the role of supplements that we use. And of course, nowadays, just in the last 25 years, I've been watching supplements. There's been an explosion of what's available and how much, and all of these different things. So it's pretty easy to get high quality supplements that can help with most of the deficiencies.
Well, that's wonderful. And I have to say, we've now run out of time, but we'll have to have you back again because there is much more, I'm sure, that you could share with us, and really appreciate it. Thank you very much.
Thank you for having me. Thank you very much.
Oh, before we go, would you like to tell people how they can contact you?
Yes, that would be wonderful. The best way for contacting me is through our new clinic in Seattle, Washington, called Advanced Medical Therapies, and the URL is advancedmedicaltherapies.com. It's just those three words run together.com, and our phone number is 206-486-1690. And that's in Seattle, Washington again.
Wonderful. Thank you. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.